Right. Okay. Right. So let's move on to let's move on to nephrology. Right. Now, nephrology is a reasonably small area. There are only a few diseases that you get in nephrology. And so let's go through them. Right. Now, the first question is on acute kidney injury. Yes, it's on acute kidney injury. Now, we discussed acute kidney injury during your clinical appointment. And I told you that acute kidney injury is a predominantly parameter-based diagnosis, right? It is next to impossible to diagnose acute kidney injury clinically, right? The reason behind that is when the clinical features manifest, they have very, very bad renal function, right? So the clinical features manifest only in the really severe cases. So we use parameters to diagnose acute kidney injury. So investigations and parameters that we can measure, right? And now this is a standard diagnostic criteria for acute kidney injury, and that is the KDIGO classification. And as you can see here, it has a creatinine-based criteria and a urine output-based criteria for diagnosis as well as staging acute kidney injury. I have to emphasize you don't need to know this by heart, but understand that it is based on the creatinine values and the urine output measurements. Right. Okay. Now, acute kidney injury, you have, when you talk about causes of acute kidney injury, we divide these causes into three groups. One, you have the pre-renal causes of acute kidney injury. You have the renal causes of acute kidney injury and the post-renal causes of acute kidney injury, right? And of these three, the pre-renal causes are the commonest cause of acute kidney injury worldwide. So on an epidemiological basis, if you look at all the causes of acute kidney injury, pre-renal causes are the ones that predominate, right? And pre-renal kidney, most of the time, it is altered renal perfusion. Right, altered renal perfusion to the kidneys, right? Reduced renal perfusion to the kidneys. However, as you can see in this slide, it can also be due to things that interfere with the renal autoregulation process. Now, in your physiology, you would have been taught about autoregulation. So, in various circulatory systems, in tissues, there is autoregulatory process. Now, there are drugs that interfere with that autoregulatory process, classically things like NSAIDs, right? And also ACE inhibitors that interfere with this renal autoregulation, which can also cause pre-renal AKI. Right, so true or false regarding acute kidney injuries, most often due to pre-renal causes, that is true. And NSAIDs as well as ACE inhibitors can give rise to a disturbance in the renal autoregulation, and that can cause pre-renal AKI as well. And in the NSAID group, it's mainly sort of disturbs this prostaglandin synthesis, right, which interferes with renal autoregulation. And that is a mechanism. Right. Now, another very, very important cause of acute kidney injury, especially in hospital-based settings, is contrast, right? And contrast causes a tubular sort of disorder, right? So it is a tubular nephrotoxin, and we have this entity of contrast-induced nephropathy, right? And we see this quite commonly in hospital. It's important also to recognize that there are lots of other things that can cause tubular damage, right? Tubular ischemia. So sometimes prolonged pre-renal insults give rise to tubular ischemia. So this can progress from a pre-renal into a renal tubular problem, right? We have prolonged ischemia to the kidneys. Infection and sepsis also interfere with the renal tubules. And also there is a long list of nephrotoxic substances that can give rise to tubular toxicity. I just mentioned that contrast is one of these tubular toxins, and also there are various types of other medication like aminoglycoside antibiotics, Amphotericin B is particularly famous, right? And when we're talking about hematology, we said that when you have intravascular hemolysis, right, this hemoglobin can be renal toxic. Rhabdomyolysis can also give rise to renal toxicity, right, because of the myoglobin precipitating in the kidneys, right? ඕක නිතරම MCQ වලට අහනවා this tubular toxins, right? Tubular toxin mediated acute kidney injury, right? So contrast is a very important thing. Antibiotics, antifungals like aminoglycosides, amphotericin B, and also free myoglobin, free hemoglobin in the renal tubules. Intratubular crystals also can occur in various medications. A classical example and something we like to ask for MCQ is acyclovir, right? The one we treat herpes encephalitis with, herpes simplex encephalitis. Acyclovir causes intratubular crystal formation, right? So these are some of the important drugs. Yes, mind, sepsis can cause pre-renal as well, yes, because it disturbs the renal perfusion, right? Because in sepsis you get a massive leak of fluid, and that causes intravascular volume depletion. So you can take it as a pre-renal cause as well. Right. Okay. So a word about contrast-induced nephropathy. So I told you it's common. It is a tubular toxin. Contrast-induced nephropathy usually manifests between sort of the maximum sort of peak is about 48 hours. So it's usually 24 to 48 hours after, 24 to 72 hours after contrast exposure that you get it. Contrast deepu gamamma, you don't get it, right? So it's usually 24 to 72 hours. Peak incidence is around 48 hours from contrast exposure, right? 48 hours from contrast exposure. Now, contrast-induced AKI, remember that patients with diabetes are at a high risk of developing contrast-induced AKI, right? So patients with diabetes. Now, the important thing is there is a lot of controversy in the literature on how to prevent contrast-induced nephropathy. One of the important things that we know is using water-soluble contrast, right, is a way of preventing contrast-induced nephropathy. Also, hydrating the patient well before and after the procedure can prevent contrast-induced nephropathy. Right? So, hydration before and after the procedure. Also, some people argue for a place for oral N-acetylcysteine, right? The evidence is a bit controversial on that front, but some people, and you might have seen in the ward also, we sometimes give oral N-acetylcysteine for the high-risk patients, right, who are at a higher risk of developing contrast-induced nephropathy. But the evidence behind that is not excellent, right? But we do use that oral N-acetylcysteine, right? So contrast-induced typically causes renal derangement, say 24 to 72 hours. So not within 24 hours, it's after 24 hours, up to about 72 hours. And the maximum incidence is at around 48 hours. So make a varadi. Gentamicin, yes, aminoglycosides are a recognized cause of acute tubular necrosis. And AKI in tumor lysis syndromes is due to precipitation of urate, right? It's urate because of the high cell turnover. They get urate crystals. So that's another cause of this intratubular crystal story, right? You get this urate crystals being formed in the tubules or precipitating in the tubules. So in tumor lysis, what happens is there's massive cell turnover. Tumor dying when you give chemotherapy, the tumor is dying, and that's releasing a lot of urate, right? Because of the high cell turnover. So urate causes crystals and precipitates in the renal tubules that can give rise to AKI. Right. So Rehani, yes, NSAIDs can cause pre-renal sort of autoregulatory issue, and rarely it can cause an interstitial nephritis as well, right? So another mechanism of NSAID-induced AKI would be an interstitial, acute interstitial nephritis, apart from its effect on the renal autoregulation. Okay, so that is question number 1. And of course, we discussed this, the classification of the causes of AKI into pre-renal, renal, and post-renal, right? And we did this in the appointment, so you are familiar with this. Right, any questions on question number 1?
Excuse me, sir.
Oh, yes, sir. Yes.
So, in this gentamicin, is it causing tubular interstitial nephritis or?
No, it is a tubular toxin, gentamicin.
All right. Okay.
Tubular necrosis.
Thank you.
Okay. There are some antibiotics that can cause interstitial nephritis. The sort of penicillin group of antibiotics can cause interstitial nephritis, right? Right. So question number 2 is again focusing on pre-renal AKI, which is the commonest cause of AKI, right? Pre-renal AKI can lead to acute tubular necrosis as well. Remember, we talked about this. Acute tubular necrosis, if it's prolonged, right? Pre-renal AKI, if it's prolonged, can lead to ischemia of the tubules and acute tubular necrosis, right? So there is a possibility of pre-renal AKI progressing into a tubular necrosis. That is right. Now, in this, statement number 2, statement number 3, 4 and 5 all are based on a very simple mechanism, right? Now, in pre-renal AKI, right, what is your body trying to do, right? In pre-renal AKI, what is your body trying to do, right? Pre-renal AKI is due to hypovolemia, reduced renal perfusion. So what your body is trying to do is it's trying to retain salt and water as much as possible. It is trying to retain salt and water, right? That is what it's trying to do because of the hypovolemic situation, right? So in pre-renal AKI then, right, the urine sodium is reduced, less than 20, right? So the urine sodium is reduced, right? And the fractional excretion of sodium is also reduced because it's trying to retain sodium, right? It is trying to retain sodium. And also because of it's trying to retain sodium and water, the urine osmolarity goes up, right? Because it's concentrating the urine in an attempt to keep back water. So there's a lot of water coming in back into the system. So the urine osmolarity increases, right? Okay. Now, so fractional sodium excretion is reduced because your body is trying to keep a lot of sodium, right, in the body itself. Urine osmolarity is increased, I told you. Urine osmolarity is going up because it's retaining the water, making the urine more concentrate, right? So it's retaining the water, and this is because of hormones like ADH. It's sort of concentrating the urine, right? Now, in pre-renal AKI, another important thing that happens is you get a disproportionate rise in the urea, right? So pre-renal AKI, urea, creatinine both go up, but you're seeing a disproportionate rise in the blood urea because that is, remember the blood urea is a very good indicator of dehydration, right? So when you have hypovolemia and low volume, the urea goes up. So in pre-renal AKI, if you examine the renal function, you see a massive rise in the urea, a disproportionate elevation of the urea. So make anit pattara tiyenne eka waradi. So in pre-renal AKI, you have a disproportionate elevation of urea compared to the creatinine. Dekama වැඩි වෙනවා because there is renal impairment, but the rise in the urea is higher. Right. Now, we'll come to statement number 3 now. depending on the etiology of the AKI, the urine might have specific characteristics. And this table I have just put down for your reference. Now, the key things to focus here are, in prerenal AKI, if you do a urine, it's absolutely normal, microscopically normal. There's nothing in it, right? But already you know, in the intrarenal ones, you can have certain changes in the urine microscopy, right? For example, in glomerulonephritis, you will find a hematuria, right? Red cell casts, right? Dysmorphic red cells. Ekata venama microscope ekak ඕනේ, but you will find these things. In tubular necrosis, you see a lot of granular casts, granular, neutrophil related, inflammation related casts, so granular casts, right? In glomerulonephritis, you see hematuria, you see red cell casts. And in interstitial nephritis, right? So there's inflammation of the interstitial space. Urine eosinophils are a characteristic finding. So you see eosinophils in urine, eosinophils. So this is important for you to remember. Right? So if it's a tubular necrosis, you are expecting to see a little bit more granular casts. If it's a glomerulonephritis, you're going to see a lot of hematuria, you're going to see dysmorphic red cells, red cell casts, right? And in interstitial nephritis, you will see eosinophils. That is an important point to remember. All right. Active sediment, the word active sediment refers to you're seeing something, granular casts, red cell casts, something, right? In prerenal AKI, you do not usually get an active sediment. It is just a bland. The word, the opposite of active is bland sediment. So you're going to see a bland sediment in the urine. Right. So this is so these two things are important, right? So you can get an idea of the cause of the acute kidney injury by looking at the urine microscopy, and also by examining things like urine sodium, urine specific gravity, fractional excretion of sodium, urine osmolarity, the blood urea to creatinine ratios are useful to define prerenal AKI. I have to say that we don't routinely do these tests because it is a clinical diagnosis most of the time. But MCQ වලට අහන දේවල් නිසා තමයි මම එක දැම්මේ. Right. Okay. Any questions about this one too? Question number 2. Any problems there?
Sir, this active cast refers to cellular cast.
Active sediment කියන එකද?
Yes, sir. Does it refer to
cellular cast? So red cell cast, granular cast, that sort of thing is referred to as an active sediment. Yes.
Right, sir. Thank you.
Good. Fine. So let's go to question number 3. So obviously first statement is wrong. We discussed that right at the start. It is very difficult to diagnose clinically, and it is diagnosed based on creatinine parameters and urine output criteria. Small kidneys and the ultrasound are diagnostic. I have taught this during the clinical appointments, right? So small kidneys are seen more with chronic kidney disease, not with acute kidney injury. Right. Now, in the acute medicine discussions we had during the proper appointment, I told you that in acute kidney injury, there are lots of complications, right? Increased bleeding is a recognized complication. That is true, right? Take a hurry. And that is because when you have uremia, you get lots of coagulation derangements. The coagulation pathway is messed up when you have high urea levels. So a manifestation of the high urea levels can be coagulopathies, right? Bleeding problems. It can cause coagulopathy, it can cause platelet dysfunction as well. So increased bleeding can be a result of either this platelet dysfunction that you're seeing or the coagulation problems, right? Now, of course, the other common things, we talked about these in detail, the complications like pulmonary edema, right? Like hyperkalemia, metabolic acidosis, because of the high urea levels, sometimes they come with encephalopathy, seizures, right? So these are all complications, right? Now, we talked about statement number 4 also during the appointment. So diuretics, you don't give it to increase the urine output. That is not the intention. It is to relieve the pulmonary edema. Urine output එක වැඩි කරන එකට නෙවෙයි diuretic දෙන්නේ. We give in AKI, we give diuretics to relieve pulmonary edema. But I told you a very important point during your appointments. This can be harmful also. So be very careful when you are using diuretics, right? If the patient is not responding, just stop giving them, right? Because diuretics can also cause worsening of the renal problems. So you have to be careful. So this statement is wrong. It's a buru katawa, right? Now, several years ago, there was a lot of interest of this low-dose dopamine in AKI. People thought it increased renal perfusion and various nonsense like that, but there is no evidence that it helps at all. So we don't give low-dose dopamine anymore. That's wrong. Right. Right. So this is a little bit about the complications and also some management things. Management we have talked about in detail, and you need to refer those notes we did during the professorial appointment. So I'm just tying everything together now in the last few weeks, so that you know everything before you go for the exam. So things of managing hyperkalemia, all these concepts we have already done. Right. Any questions about 3? Tunagana? Right. Now, this is also an important thing. Sometimes in some patients, we are able to recognize a natural history of progression, right? So we are able to recognize a natural history of progression of the AKI. And this is especially the case in patients with ATN, acute tubular necrosis. So this is something we are able to identify. Acute tubular necrosis, you see it going through several phases. Right. Now, the patient comes to you in this phase most of the time, which is the oliguric or anuric phase, which everybody is familiar with. But remember, when this phase is done and the tubules start recovering, then tubules on the way after that phase. So your tubules now start recovering now. When the tubules start recovering, they go into a polyuric or diuretic phase. Now, this is an important thing, right? So, your tubules are initially necrosed and you go into the oliguric phase, the kidneys are shutting down. But then when the kidney tubules start recovering, they progress into this diuretic phase or polyuric phase. Now, what happens there is, these new tubules which are just recovering have lower ability to reabsorb salt and water. These tubules are baba tubules. They are not able to reabsorb salt and water very well. So, salt, water goes out, right, in a massive amount. So, they get a polyuric phase, right. So, this is very important to recognize in your patients, right, because if you are not careful, it can cause dehydration, right. And then it can cause lots of electrolyte problems like sodium changes, potassium changes, just because your tubules are not well formed and they cannot absorb the sodium and the potassium and the water. So it's just polyuric phase. Right. Okay. So that is a little bit of thing to finally end off with. Right. So this is AKI then. Okay. Any questions? Right. Now, this is something that we talked about, right? Differentiating features between AKI and CKI. We talked about this during the appointment as well. And I told you that probably the only thing that can reliably differentiate AKI from CKD is the ultrasound scan, right? Probably. Now, this is a little bit of a difficult MCQ to answer because now some of the other complications like renal bone disease, renal anemia, right? Those sort of things are much more common in CKD but can also occur in AKI, right? So one of the probably only things that are very good in differentiating AKI from CKD is the ultrasound scan. If the ultrasound scan shows small contracted kidneys, that is CKD, no question. But some of the other things like renal anemia, renal bone disease, calcium, can occur in slightly prolonged AKI also, right? So be careful when you're answering these sort of questions, right? Because especially anemia, not so much these renal bone changes, but anemia can occur in AKI as well. Renal anemia can occur in AKI as well, right? Especially the prolonged AKI that takes a little bit of time to respond or resolve, right? So that is an important thing to remember. Naveen has asked, the contrast cause oliguric AKI. So contrast causes a tubular necrosis sort of picture. So it causes initially a oliguric AKI. It is difficult to say that exactly, right? So this causes oliguric, this causes non-oliguric is very difficult. Usually, this oliguric and then going into a diuretic phase is seen in acute tubular necrosis related causes. That is the thing to remember. Right. So diuretics, diuretics work in AKI to reduce pulmonary edema. Yes, because it causes pulmonary vasodilatation, right? And also causes increased excretion, but the kidneys are not working, so they might not have the increased urine output. But they cause a transient effect, pulmonary vasodilatation and sort of reduces pulmonary edema a little bit. Buddhini has rhabdomyolysis anemia usually no, right? Usually no. Right. Right. So this is what I told you. In CKD, you can see this very small contracted kidney, and it's echo bright, right? When you do an ultrasound scan, it's very white, stands out as the sudu part of the pain, and it is a contracted kidney that you see. Right. Okay. Right. Now the next few MCQs are on chronic kidney disease. Right. And we did this as a long case and I explained the management in detail. So these MCQs should be easy for you to do. Now, CKD is diagnosed again based on, diagnosed and classified based on the KDIGO guidelines. And the KDIGO guidelines currently is used, when you use it for the staging of the disease, right? There is a GFR stage, right, from G1 to G5, and there is a persistent proteinuria stage as well. Right. So currently we classify the CKD patient based on their G score, which is the GFR score, and their proteinuria score, which is A1, 2, 3. Right, A1, 2, 3. Nipuni, you're right. In another way of differentiating AKI from CKD would be that in AKI you get a transient drop in the renal function which recovers after a period of time. In CKD there is progressive deterioration of renal function. But the problem practically, Nipuni, is that make a karanna, right? Because we don't know when the patient comes in with renal function deterioration, you don't know whether it's new or old or whatever unless you have been monitoring the patient's renal functions over a period of time. Alright. So, theoretically, yes, AKI will cause a transient drop in the renal function and then recover. By CKD, progressive deterioration. That's theoretically true, but practically it's difficult to prove sometimes. Okay? Right. So chronic kidney disease has a GFR criteria and an albuminuria or proteinuria criteria, and you classify it based on that. Worldwide, diabetic nephropathy is the commonest cause, and close second is hypertensive nephropathy. Right. Now, in your clinical appointments, we talked about various complications of CKD. And in that, we talked about anemia or renal anemia. Let's revise that now. Now, renal anemia is multifactorial. First thing is that renal anemia is multifactorial. And this is important to understand. We usually observe renal anemia due to reduced erythropoietin production. Right? So one of the main contributory causes to renal anemia is reduced erythropoietin production. Right? The kidneys are the main source or producers of erythropoietin, and when there is renal impairment, it can't produce the erythropoietin anymore. So that is a main contributory factor to anemia. Right? And then lamai, there are other, but remember there are other causes. Another very important cause would be these nutritional deficiencies, like iron deficiency, like B12 and folate deficiency. That is a very, very important contributor as well. So apart from the patient not having erythropoietin, they also have deficiency of their nutrition. They have iron deficiency. They have B12 and folate deficiency. Right? And that is an important contributory cause, right? Contributory cause, right? And remember, in patients with CKD, they commonly have these nutritional deficiencies, right? And I told you this, right? Because they can't eat, their absorption is poor, right? So they have low nutrition. Another important cause of anemia in patients with CKD would be the inflammatory state, right? In CKD, there is a chronic inflammatory state, and that gives rise to this high hepcidin, which is sort of a hallmark of anemia of chronic disease, right? So that is a hallmark of anemia of chronic disease. High hepcidin levels cause an anemia of chronic disease. That is another important contributory cause. Hi. And there are various other rarer causes as well, right? Patients with CKD have increased blood loss. They have shorter end cell span, right? And they also have bone marrow related and bone related issues, right? The uremia can suppress the bone marrow production of red cells. And also in this renal bone disease, the bones inside health of the marrow reduces. Right? And unusually enough, ACE inhibitors can also cause anemia in CKD, right? It's not a very common thing. The mechanism is slightly complicated. Don't worry about it at the moment. Right? So that can also cause right? It's sort of the mechanism sort of is related to erythropoietin consumption ACE inhibitors, right? But not very important. Right. Now, renal anemia usually manifests when the GFR is less than 60. You start seeing it when the GFR is less than 60. So Tharuk Khan is asking erythropoietin therapy walatam anemia inna puluwanda. That might sound a silly question, but it is a very, very rare side effect of erythropoietin, right? Very, very rare side effect of erythropoietin. It causes something called pure red cell aplasia, right? Some erythropoietin preparations cause pure red cell aplasia. Bone marrow red cells tika marino, right? That's a very, very rare side effect of erythropoietin, right? So MCQ එක අහලා තියෙනවා නම් ඉතින් ඒක true තමයි, but it's a very rare side effect. Very, very rare side effect. Right. True or false regarding anemia in CKD becomes evident only when the GFR declines more than 15 කෙනෙක් බයිලා කතාවක්. 60 වෙනකොට you will see this. It's commonly microcytic hypochromic නෙවෙයි. What we see is usually it's normocytic normochromic. If it's microcytic hypochromic, then anemia due to iron deficiency is the driver there, right? That is the main contributor. Most patients will have a normocytic normochromic anemia. Most patients, right? Impaired red cell survival is a contributory cause. Matakane in the slide I told you, they have a impaired red cell survival, right? Because of, again, this is because of the uremia, right? And they are bleeding as well. They have higher risk of bleeding. Uremia valadi, you can get platelet dysfunction. The coagulation pathways are a bit off, so they have increased risk of bleeding as well. Right. Now, how do you manage anemia in CK? Important thing is make sure you correct. Make sure you correct the nutritional problems first. Remember, I'll discuss it in the long case. If there is iron deficiency, treat the damn iron deficiency. Don't just whack the patient with erythropoietin. So the basic principle is erythropoietin you have to give, but you have to correct any nutritional problems before that. Blood transfusions are given only if there is nothing else to do or the patient is very, very symptomatic. Blood transfusion. The reason for that is because, especially if they are going for transplant, long case. When they are going for transplant, if they have a lot of blood transfusions in the past, they have a high risk of graft rejection because they develop various antibodies which are floating around, right? Blood deepu gamam, they develop various antibodies which are now sort of floating around. So we don't give them a lot of blood transfusion. Anemia and CKD is reversed with dialysis baila katandare eka gon katawak eka waradi. Right, you can't reverse it. Right. So this is the sort of thing to remember, causes of anemia in CKD. Any questions about question number 5?
So that last statement, reversed with dialysis, uremic anemia has
if there is a uremia induced platelet dysfunction or something, that will get a bit better, but it is not reversed with dialysis. That's a broad statement. You can't say it's true because of that only. Right?
Right, okay.
But of course, you will get transient improvement in the platelet function, right? But of course, you can't say it is reversed. Right? Okay. Right. Now, I told you about the management of Katakara. Again, I emphasize the important thing is treat the iron deficiency before you give erythropoietin and try to avoid blood transfusions because you are at a risk of developing antibodies to these. Now, how do you diagnose iron deficiency? Please write it down. So, one method where we use is looking at the amount of hypochromic red cells, right, in the blood. In a blood film, you can look at the amount of hypochromic red cells. So as I told you, hypochromic red cells indicate iron deficiency, right? Another way of diagnosing iron deficiency is to go by the iron profile, iron studies. But cutoffs chuttak venas e nisa eka kohari liya ganna. The cutoff is ferritin less than 20%, transferrin saturation less than 20%, ferritin less than 100 in a non-dialytic patient, less than 200 in a dialytic patient. So, transferrin saturation less than 20% overall, less than 100 ferritin in a non-dialytic patient, less than 200 in a dialytic patient. Right? So these are the cutoffs to diagnose significant iron deficiency. So either use the percentage of hypochromic cells or you use the ferritin as your guide. Ferritin as your guide. Sachit, if there is no plan for kidney transplant, is it okay to give blood? Again, Sachit, try to avoid it, but anyway, blood transfusion risk. Why do you want to take a risk, right? Unless the patient is extremely symptomatic or not responding to something, will you give blood transfusion? In anything that is the case, because there are risks of blood transfusion. Hari. Okay. So that is question number 5 done. Now we move to question number 6, which is on renal bone disease. Right. 6% is the cutoff guide for hypochromic red cells. So more than 6%. मैं वो टेस्ट එක ටිකක් මේ fresh blood sample එක කරන්න ඕනේ. මෙතන තියෙනවනේ පැය 6ක් ඇතුළත කරන්න ඕනේ කියලා. Right. Now we go to renal bones. Now this is again something I did in detail during the prof appointment. Long case එක කරනකොට මම මේක pathophysiology එක ඔක්කොම ඔයගොල්ලෝ උගන්වලා තියෙනවා. ඒතර ආයි ලොකුවට details කරන්න යන්නේ නැහැ. But essentially renal bone disease is a mix of various things, ne? Right? Please, I hope you remember these things. Renal osteodystrophy is due to the hyperparathyroid state, right? That occurs. Hyperparathyroid state, right? And that is because of the phosphate retention and the low calcium, right? So that is renal osteodystrophy due to hyperparathyroidism, which is usually secondary but can transform into tertiary hyperparathyroidism, right? ඒ දෙකේ වෙනස තමයි tertiary එකේ there is no regulation of the secretion of PTH. ඕගාලා හැදෙනවා. There is no regulation or any control in the formation of PTH. There is a massive production. විකටම හැදි තියෙනවා. There is no feedback or there is absolutely no regulatory mechanism in play, right? So it is a big problem, right? So that is that. So renal osteodystrophy. Osteomalacia is another thing that can exist, and that is due to the vitamin D deficiency. The deficiency of active vitamin D, they get osteomalacia. Right. තව කතාවක් මම ඔයගොල්ලන්ට කිව්වා adynamic bone disease කියලා මතකද? ඒක මම කිව්වා. I'm just going to remind that to you, right? So adynamic bone disease මතකයි මම කිව්වා you need a little bit of PTH for healthy bone turnover. You need a little bit of PTH for healthy bone turnover. Now by giving medication, right, because most of the time it is a secondary hyperparathyroid state, your medication is trying to suppress the PTH. So you're giving calcium, vitamin D, you're suppressing the PTH, right? If you overdo it, right, it can cause adynamic bone disease. So if you overdo your suppression, it can cause adynamic bone disease. So එකයි මෙතන මේ කියලා තියෙන්නේ, right? Over suppression එක වළක්වන්න කියලා. It can cause adynamic bone disease. මේක පොඩ්ඩක් මතක් කරගන්න ඔයගොල්ලන් පාඩම් කරන නිසා long case වලටත් මම මේවා උගන්වලා තියෙනවා. හරි? So secondary hyperparathyroidism, osteomalacia, adynamic bone. And also you can get osteoporosis as well in CKD, right? Osteoporosis. Right. So let's do the MCQ. In renal bone disease, so in CKD, gut absorption of calcium is increased. The gut absorption of calcium is mainly dependent on vitamin D, right? And I told you a few minutes ago that these patients have lower amounts of active vitamin D. So gut calcium absorption so it's very low. It's a very low gut calcium absorption. Hypophosphatemia is characteristic. Again, because why? The main problem in CKD is that they have phosphate retention. That is the main problem, right? They cannot excrete phosphate. Patients with CKD cannot excrete phosphate. So their phosphate is very, very high. That is the fundamental problem there. The phosphate being significantly high. That is the main problem. So phosphate is high, and because of the vitamin D problem, the calcium is low, right? That is the fundamental problem, and it triggers off the PTH. High phosphate, low calcium triggers off the PTH. That is the main problem. So it's a variant. Right. Hypercalcemia does not occur, right? Hypercalcemia does not occur. Ekak වැරදි. Right. This happens in this condition, tertiary hyperparathyroidism. දැන් සාමාන්‍ය මොකද්ද තියෙන්නේ? High phosphate, low calcium. right? And when you now manage this, api denawa vitamin D denawa, we give calcium, you're suppressing the PTH. So calcium normalized වෙනවා ටික වෙලාවක් යනකොට. But if they develop the state of tertiary hyperparathyroidism, there is no control to the PTH, right? No control. So what happens is the calcium now starts to go up. So patients with tertiary hyperparathyroidism can have hypercalcemia, right? Because the PTH there is no control, there is no regulation of the PTH secretion. So this causes a whole load of calcium to come out of the bone marrow, causing hypercalcemia. කළා එතන ඔයගොල්ලෝ notes මේවා ලියා ගන්න. The hypercalcemia is a very dangerous thing in CKD, right? They usually have very poor prognosis, right? Hypercalcemia causes vascular calcification. It is a very dangerous situation. So hypercalcemia does not occur කියන එක වැරදි, that is false. It can occur when they have tertiary hyperparathyroidism. Okay. The next one is alkaline phosphatase. Of course, it is elevated because of the bone resorption, because the parathyroid hormone, alkaline phosphatase. Right. The final one, I just told you that suppression of PTH එක හොඳ නෑ. ගොඩක් over suppress කරන්න හොඳ නෑ. Target එක guideline වල කියන්නේ 3 to 8 times upper limit of normal තියාගන්න කියලා. So that is the target. So upper limit of normal 3 to 8 times තියාගන්න ඕනේ PTH level එක. Now in other countries, obviously more developed settings and people who have money, we monitor the PTH levels. So usually the guideline is to maintain the PTH about 3 to 8 times upper limit of normal in a CKD patient. Right? And that prevents the adynamic bone disease from setting in. The physiological limits ඊටතේ චුට්ටක් උඩින් තියාගන්න තමයි ඕනේ CKD වල. And that is to prevent the over suppression and the sort of adynamic bone disease. Hi. Okay. Any questions about this?
Sir, one terminology question. So is renal osteodystrophy this umbrella term for this whole thing, or is it very specific to this?
No, it's specific for hyperparathyroidism.
Just a secondary hyperparathyroidism.
ඒක hyperparathyroidism වල changes වලට තමයි renal osteodystrophy කියලා කියන්නේ.
All right.
Yeah?
Okay.
Right. So these are some of the things that you see. So this in hyperparathyroidism, you see this very classical multiple lytic lesion, myeloma වල වගේ පේනවා in the skull. This is called a rugger jersey spine that you see in osteomalacia. Right? Rugger jersey spine කියලා එකක් තියෙනවා. Right. Okay. Right. Another thing that you see are these small fractures. මෙන්න මේ table එකෙත් ඕක ටික තියෙනවා. හරි? Right? So some of the other changes you see in renal bone disease are these looser zones කියන ඒවා mostly Malaysia වල තමයි ඒවා ඉන්නේ. මෙන්න මෙතන මේ පොඩි fractures වගේ තියෙන මෙන්න this is a looser zone. හරි? Just pictures. අශ්වහල තියෙනවා ALP එක අඩු වුණොත් ඒක හරිද කියලා. ALP අඩු වෙන එක detect කරන්නේ නැහැ අපි සාමාන්‍ය. It is not a common thing that you can detect. හරි? But theoretically, yes, in adynamic bone disease, the ALP can go down, but ඒක අඩු වෙන්නේ නැහැ. It is in the normal level. හරි? Right. මේක නිකන් කටපාඩම් MCQ එකක්. මේකේ ඔක්කොම උත්තර ටික ඊගාව ස්ලයිඩ් එකේ තියෙනවා. හරි? ඒක නිකන් කටපාඩම් MCQ එකක්. Unfortunately, දෙන જાතියේ කටපාඩම් MCQ එකක්. So I have given you in this slide all the endocrine and metabolic alterations you can get in CKD. So like hyponatremia is very common. You already know that hyperuricemia is common. ඔය thyroid එහෙම අඩු වෙන්න පුළුවන්, වැඩි වෙන්න පුළුවන් එක එක දේවල් වෙන්න. Mostly hypo පැත්තට තමයි බර වෙන්නේ. Right? So this is just for your reference. Right. Any questions up to now?
So are we going to take hypercalcemia as true or false?
Hypercalcemia can, yes. Yes, it is true. It can happen. Yeah. But most of the time it is hypocalcemia. You can get hypocalcemia and hypercalcemia as well, especially if the patient has tertiary hyperparathyroidism, you are going to get hypercalcemic, right?
Okay.
Which is a very dangerous scenario. How does CKD cause half and half nails? Interesting question. I don't know the answer to that directly, but I can check and let you know. All right. Okay. So usually renal anemia, especially the erythropoietin deficiency, sets in when the GFR is less than 60, Kavisha. Yeah. Right. So management of CKD. Now here we be very careful about this first statement. Now I told you in the management of CKD, again referring to your long case that we discussed in detail, I talked about early stages of CKD. ACE inhibitors are very useful. Early stages, right? They reduce proteinuria, right? They limit the progression of renal injury. So ACE inhibitors are good in the early stages. But in the late stages, they are problematic because they can cause hyperkalemia. But they are never contraindicated. That word is wrong. It's not never contraindicated. Early stages, it is indicated because it is has an antiproteinuric effect, right? Later stages, it is very troublesome and we avoid it because of the risk of hyperkalemia, right? So that is the story. Right. Now, when we talk about renal anemia, in the long case, target hemoglobin of 9 to 10 is more than enough, right? 9 to 10 are more than enough. Actually, some studies have shown that increasing it beyond that can actually cause problems, right? So, we usually aim for a 9 to 10 target. Very rarely erythropoietin can cause pure red cell aplasia. Right. All right. Now, about the management of renal bone disease, what do you do? So the common scenario, you get a hyperparathyroid state. So what you are trying to do is, you are trying to suppress that hyperparathyroid state by giving vitamin D and phosphate binders, like calcium carbonate. But sometimes you're worried about the calcium level, right? Where calcium carbonate, then you've got calcium very and if there is tertiary hyperparathyroidism, again the calcium is going to go up. So when you're worried about the calcium, we give non-calcium containing phosphate binders. Sevelamer is one of them. There is another one called lanthanum carbonate, right? These are non-calcium containing phosphate binders. Expensive, but you give these when you are worried about the calcium, right? It's not good to have a high calcium in patients with CKD because they get vascular calcification, right? And that is the place for these non-calcium containing preparations. The last one, right. Okay. Last one I already said. So vitamin D analogs, anything that suppresses the PTH has a potential to cause adynamic bone disease. So that's why you maintain it within that target of 3 to 8 times upper limit of normal. Right. So that is question number 8, Lama. Any questions on this one?
Sir, is there a sort of a target range for calcium we need to?
There is. So it's sort of, you can bring it up to normal, but nothing more, right? I can't remember it off the top of my head, but in these guidelines, they do give a calcium target. Yes.
Right.
No.
Excuse me, sir.
Yes, Karan.
So in these patients, like since in the early stages and all, like we want to prevent the proteinuria, can we use something like diltiazem or spironolactone?
You can use, so ACE inhibitors are antiproteinuric drugs. Spironolactone, not so much, but ACE inhibitors, yes. Diltiazem, yes. Then things like amlodipine also have some antiproteinuric action. right? So it's not only ACE inhibitors, angiotensin receptor blockers, diltiazem, all these have antiprotein activity.
And diltiazem you can use in the later stages as well.
You
right?
can, yes, you can, yeah, because it's a calcium channel blocker. Yeah, it doesn't have any problems with hyperkalemia. All right, okay, right? Okay, so that is CKD done. Right, now we move to glomerular disease. Again, something we did during the long case. Now, just to recap, glomerular disease has it's a spectrum of presentation. And this picture, you might have seen this in Davidson, of course, if you read that, I don't know whether you do, but you would have seen this picture, which is a very useful picture, right? So, glomerular disease has a spectrum of presentation. On one hand, they have very predominant proteinuria, and they present with nephrotic syndrome, right? On the other hand, they might have hematuria, and they present with nephritic syndrome. And at the top, there are certain etiologies that have a tendency to produce proteinuria more and nephrotic syndrome more. So, etiologies and also pathological patterns that present more with proteinuria and nephrotic syndrome. For example, minimal change, FSGS, diabetic nephropathy, those present more with a nephrotic picture. Whereas things like post-streptococcal glomerulonephritis, the vasculitis, those present with hematuria and nephritic syndrome. Right? So that is a nice way of remembering what exactly goes on. Right? And remember, in the nephritic syndrome, if you look at their glomeruli, they will have a lot of inflammation. Inflammatory cell infiltrate. Crescent formation. So there is a distinctness in the pathology as well you see in the kidneys. Right? So this is an important thing to remember. This is an easy thing, right? What are the features of nephritic syndrome? So hyperlipidemia is a nephrotic thing, right? Plasmodium increases, right? Serum albumin again is nephrotic, sorry. ESR, yes, can go up in nephritic. New onset hypertension can go up in nephritic. This is easy. Yam prathamika level එකේ ප්‍රශ්නයක්. ඒක. Right. This again, unfortunately, is a කටපාඩම් MCQ. Causes of nephrotic syndrome කියලා ඕම් 500ක් විතර මෙහෙමයි. ඕක මතක නැති වුණත් මේක වැරදියක් දෙන්න බෑ ඕන ලම්බකින් nephrotic syndrome වෙන්න පුළුවන්. So බය නැතුව ඔක්කොම true ගහුවත් කමක් නැහැ. Right? But I have given you for reference all the causes of nephrotic syndrome in this slide. හරි? તો ඔක්කොම ටික හරි ඔය ටික. හරි? ඕන එකක් හරි ඉතින්. එන එක. වැරදිව දෙන්න බෑ. මේ වගේ වැරදිව දෙන්න බෑ. මොකද කොහේ හරි case report එකක හරි ඔක තියෙනවා. එතකොට ඉතින් වැරදි නෑනේ. So most of the time these sort of things are true. Everything is true. Right. සඳමිනි මේ amyloidosis ගැන ප්‍රශ්නයක් අහලා තියෙනවා. Yes, amyloidosis can have sometimes enlarged kidneys on ultrasound scan because it's an abnormal protein that deposits on the kidney, right? Right. Okay. Right. Okay. Now, minimal change can be normal as well. Yes, normal or increased size level. Now, question number 11 is asking on minimal change. So, minimal change disease is a very common histopathological diagnosis of that you see associated with nephrotic syndrome. So, patients who have nephrotic syndrome, children, almost everybody has minimal change, right? Adult nephrotic syndrome will see a lot of membranous nephropathy, right? Adults, like, not minimal change. Children, yes, definitely it is minimal change. Right. Yes, Hasni, ACE inhibitors can reduce protein as well as cause nephrotic, but nephrotic syndrome any rarely, very, very rarely. Right? ඔයගේ rare දේවල් මතක තියාගන්න එපා. හරි? මේ list එකේ තියෙනවා. හරි? captopril. Amazing, captopril you can get nephrotic syndrome. Right. කටපාඩම් දේවල් තමයි ඉතින් හරි. අයින් කරන්න ඕනේ. This true false thing has to go, right? But unfortunately still there. Useless. No point. Right. So commonest cause of nephrotic syndrome in adults කියන එක බයිලා කතාවක්, ඒක බොරු කතාවක්. ඒක වැරදි. Minimal change nephrotic disease can have a familial association. We do recognize congenital or familial nephrotic syndrome. Right. Minimal change disease can occur due to various secondary causes as well. Okay, list එකක් මම කොහේ හරි දීලා තියෙනවද කියලා මතක නැහැ. මේ තියෙන්නේ. හරි. මෙහෙම බගුවකුත් තියෙන ඔයගොල්ලෝගේ notes වල minimal change වලට secondary causes ටිකකුත් තියෙනවා. හරි. මේ table එක ඔයගොල්ලෝ පොඩ්ඩක් සැර වැඩි. But you can get something out of it. Just have a read through it. හරි. හරි. මේකේ තියෙන ටිකක් තතන්දරයක් උඩ. හරි. Now, minimal change disease, light microscopy, is usually normal. That is what the name comes up as, minimal change disease. But you can sometimes see a little bit of tubular lipid deposition. හරි ඒක මේකේ තියෙනවා උතන. හරි පොඩ්ඩක් lipid tubules වල පොඩ්ඩක් තියෙන්න පුළුවන් lipid deposition එකක් තියෙන්න පුළුවන්. Sorry. Right. Now, minimal change can progress into CKD. Does not progress into CKD කියන එක බොරු කතාවක්. It can progress into CKD. So what you have to remember is minimal change is this classical prototypic nephrotic syndrome presentation. Minimal change තමයි ගොඩාක් children nephrotic syndrome in children, that is almost always minimal change in histopathology. Right? බලනකොට. This is just talking about etiology and sort of prognosis of it. Right. මේවා ඔයගොල්ලන්ට පුරුදු ඇති. In pediatrics also they ask very similar questions. So this is referring to minimal change disease. Produces highly selective proteinuria. මේක pediatric වලට ඔයගොල්ලෝ definitely උගන්වනවා. හරි උගන්වනවා. Compared to the other sort of things like FSGS, membranous, other histopathological causes of nephrotic syndrome, also the patterns associated with nephrotic syndrome, minimal change වල you get a very selective proteinuria, right? Albumin විතරක්ම වගේ තමයි යන්නේ. Complement levels are usually normal. Complement levels are low in patients with a lot of more aggressive inflammatory type glomerular nephritis, like post-streptococcal glomerular nephritis, lupus nephritis වගේම you have the complement low because these immune-related inflammatory sort of glomerular nephritis, they consume complement, they use complement, right? Use up the complement, so the complement levels go down. But in minimal change disease, the complement levels are usually normal. Relapses are extremely uncommon කියන එක බොරු. Actually, in adults, minimal change can cause more relapses compared to children. So, ළමයින්ට සාපේක්ෂව minimal change in adults is associated with a higher relapse rate, and also the response to steroid is not as good as in adults. Steroid responsiveness එක adults ලගේ තරම්ම හොඳ නැහැ. හරි? ඒ තරම්ම හොඳ නැහැ. When it comes to adult minimal change disease. And in those sort of situations, we can use drugs like cyclosporine වගේ drugs or cyclophosphamide වගේ drugs පාවිච්චි කරන්න පුළුවන්. So the main differences with minimal change in adults and children is minimal change in adults is less common, is a less common cause of nephrotic syndrome, right? They have more relapses and response to steroids is less, right? Compared to children. So Rehani complement levels adu වෙන්නේ in something that is extremely sort of inflammatory, immune mediated එකක වගේ තමයි complement levels adu වෙන්නේ, like SLE, like post-streptococcal, right? මේ වගේ minimal change වල there is no active immune mechanism that is working, so they don't use their complement pathways. Yeah. Right. Okay, and this is just for your reference. Now, I told you that glomerulonephritis has two classical presentations. On one hand, they have proteinuria and nephrotic syndrome. And if you look at their histopathology, they have minimal change disease, FSGS, membranous, right, and things like diabetic nephropathy. On the other hand, they might have hematuria and nephritic syndrome. And one of the classical nephritic syndrome presentations would be something like post-streptococcal glomerulonephritis. So this MCQ is that. And I told you that in these sort of nephritic syndrome related ones, they have a more active immune response. Their kidneys, if you cut them open, there are lots of immune cells in the glomeruli, immune cell infiltrates. There is crescent formation, right? And also complement consumption, right? So these are the things that you see. Right, so post-streptococcal glomerulonephritis is due to streptococcal or post-streptococcal infection. Right. Low complement levels. Yeah, because it's an active immune process, right? And that is that. And it uses up the complement levels. Crescent formation is seen on renal biopsies. True, that's what I just explained, that they have a high immune infiltrate, very cellular glomeruli, and crescent formation is a histo feature that you see. And these patients, remember, have these sort of immune complexes which are deposited in the sort of endothelial, subendothelial region. And they contact with the bloodstream very easy, right? So subendothelial deposits are seen. Endothelial or subendothelial deposits tamai godak යාට these immune complexes go and stay there. Right. Okay. Post-streptococcal glomerulonephritis is a self-resolving thing. You don't need to use steroids, ඒක බොරු කතාවක්, right? It is usually self-resolving, right? Resolves on its own, right? Resolves on its own. Right, and this is a little bit of a note on few additional points on post-streptococcal glomerulonephritis. Right, a few questions in MCQ. So adults lage actually, so would you ask adults lage minimal change, relapse rate is higher, poor response rate, actually progression to CKD is also higher in children, adults. So adults like a progression to CKD, then the relapse rate is high and the response to steroids is also not as good as adults, children, sorry. Chamatka and minimal change disease, you can see it under the light microscope, yes. Aren't crescents? So crescents are formed in, so remember, rapidly progressing glomerulonephritis is a clinical syndrome, right? Where they come with a nephritic picture and go into AKI. Right, so even post-streptococcal glomerulonephritis can progress into a rapidly progressive glomerulonephritis. This is a clinical syndrome where they come with nephritic syndrome and progressive rapidly into AKI. Other causes of rapidly progressing glomerulonephritis are vasculitis, right? Lupus වලට එන්න පුළුවන්, right? So it's just a clinical entity, right? ඔය හැම එකකම crescents එන්න පුළුවන්. Right.
Sir, in the table of yours, it says this PSGN there is low C3 with a normal C4, but as an overall statement, we took this normal.
Complement අඩු වෙනවා කියලා normal. ඒ කියන්නේ you can ගන්න පුළුවන්. ඕකේ ඔය තියෙනවා පොඩි scene එකක් දෙකම අඩු වෙන ඒවා තියෙනවා එකක් අඩු වෙන ඒවා තියෙනවා ඒවා ඇත්තටම ඔයගොල්ලන්ට ලොකුවට පද වෙන්න අවශ්‍ය නැහැ. Right?
Right. Thank you.
But generally if the complement is low, that is true. No problem there.
Excuse me, sir.
Yeah.
Normally, then adult කෙනෙක්ගේ ගත්තොත් adult nephrotic syndrome commonest cause එක diabetic කියලාද normally ගන්නෙ?
Overall diabetes, if it's idiopathic, it is membranous.
Right. ඒ කියන්නේ දැන් අර pathological diagnosis එක නේද අපි minimal change හරි
minimal
FSTS
change
හරි
membranous එහෙම කිය
membranous
කියන්නේ.
හරි.
Yes. Yes.
ඒකට අර etiology එක ගත්තම ඒක diabetes නේද?
That is right. Yes.
හරි.
Right. Now the last MCQ මම නිකන් දැම්මේ මේක නම් අහන්න ගන්න නැහැ සම්බන්ධ නැහැ. Just to complete or round things off, question on polycystic kidney disease. Now this is a classical image of polycystic kidney disease with the cysts you can see very nicely here, right? There are two types of polycystic kidney disease. Of them, the adult variety is a mutation in chromosome 16, right? That is the important variety that we see. Our rare එකක් තියෙනවා, ඒක don't worry too much about it. Right. Now remember, patients with adult polycystic kidney, CKD comes on usually in the sort of 4th to 5th decade වගේ. And also remember, cysts පේන්න ගන්නේ අවුරුදු 30 40 විතර පැන්නම ගොඩක් අය. ඔය ළමයින්ගේ adolescents ලගේ you don't see the cysts even when you scan them, right? So they usually develop the cysts around say 30, 25, 30 plus, and they become CKD 4th, 5th plus decade, right? And later on in life. So CKD present the second decade of life is absolute nonsense. It is develops when they are 50s, 60s, වගේ යනකොට තමයි they develop CKD. Even the cysts cannot be seen when they are very young. Right. Now remember that cysts not only occur in the kidneys, they can occur in the liver as well. So it's associated with hepatic cysts. It's a true statement. Take a hurry, right? So there is a possibility that you can get hepatic cysts. Right. Okay. And also, this is another famous thing, patients with polycystic kidney can get various other manifestations. When I list එකේ උතන තියෙනවා. Berry aneurysms are common. These are extrarenal manifestations. They can get aortic regurgitation, aortic aneurysms, right? And also, polycythemia is an unusual feature. ඕක හරි මේකක් තියෙනවා ඔය මේ patients with polycystic kidney CKD, they actually have polycythemia. And that is because these cysts can secrete erythropoietin, right? So even though these patients go into end-stage renal failure, sometimes they are polycythemic. Right? So that is a special thing that you need to remember. Right? So intracerebral aneurysm is associated. Cyst infection is best treated with coamoxiclav is wrong, right? So you don't give coamoxiclav for cyst infection here, right? අපරයක් දෙන්න මෙසේජ් එකක් තියෙනවා. Sorry. Right? So the drugs of choice for cyst infection are things like ciprofloxacin or cotrimoxazole. ඒ වගේ දේවල් තමයි. These are cyst penetrating, right? coamoxiclav වගේව දීලා වැඩක් නැහැ. Right. So that is a little bit about polycystic. I'm not sure you will get an MCQ, but if they give it, that is all they can ask or we can ask. Right. Right. So I told you that infectious cysts වලට ciprofloxacin වගේ දේවල් දෙන්නේ. And now there are some drugs that sort of this vasopressin antagonist can cause a reduction in cyst size. There are some trials now which are ongoing. So usually Rasika 25-30 විතර පැන්නම තමයි cyst පේන්න පටන් ගන්න. So 30 plus තමයි screen කරන්නේ සාමාන්‍යයෙන්. 25-30 age එක පැන්නම. Right. Best response MCQ තියෙනවා. Okay. So cutoff values 20% less than 20% of transferrin saturation, and then the ferritin 100 in a usual CKD patient and 200 in dialysis patients. Right. ESR can increase in nephrotic also, but not a lot. පොඩ්ඩක් නිකන් වැඩි වෙනවා, ගොඩක් වැඩි වෙන්නේ නැහැ. හරි, okay. Right, so let's go to this one. Right. මෙතන මම පොඩ්ඩක් මේ wording එක පොඩ්ඩක් කවුල් කරගෙන තියෙනවා. මේකේ point එක තමයි sore throat එක is persistent during the hematuria episode කියන එක තමයි point එක. මට ඒක එහෙම හදාගන්න එක. Right. I want to teach you something with this best response. Now there are two syndromes that look very, very similar. Hari බොහෝම එක ළඟ යන syndromes දෙකක් තියෙනවා. One is post-streptococcal glomerulonephritis, and the other one is another disorder called IgA nephropathy. IgA nephropathy. Right? These are very similar, right? They both cause nephritic syndrome, right? They both cause nephritic syndrome, right? So that is right. They both cause nephritic syndrome. Both cause nephritic syndrome. But the main difference is in post-streptococcal glomerulonephritis, the nephritic syndrome comes about 2 weeks after the sore throat or skin sepsis, mostly skin sepsis. But IgA nephropathy, the sore throat එක තියෙනකොටම තමයි hematuria again. It's called synpharyngitic hematuria that they get. Right? Synpharyngitic hematuria කියලා ඔකට කියන්නේ. Right? So that is the main story there. Right? That is the main story there. Right. And also මේ C3 C4 කතන්දරේ වැඩි කලබල වෙන්න එපා. ඒ දෙකම අඩු වෙනවා IgA nephropathy වල. So the answer is IgA nephropathy. ඒක උගලට වැඩක් නැහැ. So I want to teach you this. Synpharyngitic sore throat hematuria is most likely IgA nephropathy. If they get delayed nephritic syndrome, that is post-streptococcal. ඒක මතක තියාගන්න නැහැ. Right. Now, question number 2, there is some story of amoxicillin දෙනවා, diclofenac දෙනවා, ලොකු කතන්දරයක් තියෙනවා. The important point here is that the patient has eosinophilia in peripheral blood, right? Right, and also මේක දීලා නැති වුණාට what is the relationship between this whole story and eosinophilia? This is the acute tubulointerstitial nephritis. And I told you, even if you look at the urine, you will find eosinophils in the urine as well in these patients. So this is both amoxicillin and Rehani asked the question earlier, diclofenac can also cause a tubulointerstitial type nephritis. Right? So these are sort of, this is a tubular. So the important thing is eosinophilia is a key point in diagnosing tubulointerstitial nephritis. Right? Blood eosinophil වැඩි වෙන්න පුළුවන්. Also urinary eosinophils can also be positive. So that is interstitial nephritis is the answer here. Any questions about that one? Right. What is the diagnosis here? There is some hematuria, hypertension, renal impairment. The clinching point in this one is father died of SAH at 642, family history of renal problems, Arakameka, Russian. So this is polycystic kidney disease. I just told you that can cause saccular aneurysms, say renal aneurysms in the pulluang. Okay, so that is that. And of course, you would do an ultrasound scan first to see whether there are cysts. 26, you will see a few cysts at this age, usually. So, ultrasound abdomen. Right. 59-year-old man with chronic renal failure, there is anemia with a ferritin of 10. Right, ferritin of 10. Okay. So what is the story? There is clear iron deficiency. I told you the criteria for iron deficiency. So that is, this patient clearly has iron deficiency. So remember, in this patient, you have to start the patient on iron before erythropoietin, right? That is very important, right? That is very, very important to make sure that you start the patient on iron therapy. And we talked about this in a long case as well, Lamai. In patients with CKD, generally we prefer IV iron. It has a better response because oral dunnama hari karadare, it doesn't get absorbed and various issues, right? So IV iron is what is preferred here, right? In patients with CKD, IV iron works better, tried and tested, right? So because of the predominant iron deficiency, low ferritin, you are giving iron. Ashwa, ultrasound scan. So Ashwa, you have a point there. Currently, the gold standard is supposed to be MRI of the kidneys. But you can take the ultrasound as the answer. Right? But currently, the sort of gold standard is sort of MRI. MRI kidneys. Right. So question number 5 is again, the story is very clear, right? There is a acute tubular necrosis, right? That is very clear. Because of the sort of a prolonged cardiogenic shock, renal perfusion has gone off, right? So what happens is when, as I told you, when you get prolonged loss of renal perfusion, right? Then you get ischemia and tubular necrosis. So this is what is happening here. And you can see the story of the oliguria, polyuria shift as well. And we know that there is a tubular necrosis going on, right? So patchy tubular necrosis is the answer. So IV iron in Supuna, IV iron in CKD patients is standard usually. Oral iron in Pulvam, but usually IV iron is preferred. Especially in patients who are undergoing dialysis, IV iron is preferred. Yeah, both patients, unless they are very early on, the iron deficiency is not very bad, you can give them oral. But currently the trend is to give more IV iron. And it is just 2 injections can sort the problem out. Right. This one will do diabetes sector. Right. Question 7, acute weakness by the potassium is blood is sky high, right? And obviously the first thing you have to do is give calcium. Right? Yeah. Right? That is the first thing you need to do to stabilize the myocardium. So, guys, tubulointerstitial nephritis and interstitial mean the same thing. Yes. They refer to the same things. Hurry. Okay. Job done. So, nephrology finish. Yeah. Right. So, yeah, any questions? So, in nephrology, basically you have AKI, CKD, and glomerulonephritis, and a little bit of polycystic kidney. UTI ගැන MCQ දෙනවා අපි ඉන්ෆෙක්ෂන් යටතේ කරලා දාමු. හරි මෙතෙන්ට අද ගන්න නැතුව. No. So yes, in a way you give calcium glutamate very easy, but when the potassium is very high, more than 7.5, you have to give it anyway, right? So it is a good thing to give it anyway. So that's life threatening level එකට ගියාම ඔය මේ බල ඉන්නේ. Right. Any other questions, ළමයි?
Sir, does the tertiary hyperparathyroidism affect the phosphate level?
Not commonly, no. It's mainly calcium that is affected.
Okay.
Yeah. So guidelines will say 6.5 as severe hyperkalemia. Right? Yeah. Sachita. Okay. සමත් හරිද එහෙනම්?
හරි සර්.